We're going to shift to the PTE measures. So how do we get there? For MeChip, we have an advisory group made up of lots of different people. We are actually participating in the National Improvement Partnership Network called NIPIN. It's really looking at identifying child health care priorities in Maine, advising first steps in the IHOC project, as well as Ted has asked us to look at the metrics. And that's been a big part of what we've been doing. Like Ted was saying earlier, if you think your healthcare system or organization has not been involved, there probably has been someone there. We actually have a large list of organizations who are working with us on MeChip, and we've listed some of the physician leaders in quality improvement that have been across the state. We've had heavy participation from Steve Giovanni, who's down at Maine Medical Center, Mike Ross, who's up at Eastern Maine Medical Center, Tora Tomasi and Eric Levitt, who is at CMMC. Ned Claxton is on our MeChip advisory group. And we've had lots and lots of people that are listed here. So we've really been working with the physician community, the provider community on this. Okay, here we are. This is the page I want everyone to look at in your handout. PTE childhood immunization metrics, benchmarks, and scoring. So, everyone's got their handout. What we looked at is before with PTE, you guys were measuring basically what Impact 2 looks at for rates or practices. The 7 immunizations at age 2. That's what you guys had, and then we need to update it to the current recommendations.
Just for those of you who remember, we haven't updated our immunizations for like 5 years. They're the same ones that Jan and I put together like in 2007 or something like that.
So, you're ready for an update. So we've added rotavirus, influenza, your end of the season flu rate. So not what you would find in January, but really at the end of the year, what did you achieve for flu and hepatitis A? And age 13, we really felt it's important to add adolescent immunizations. We really need to start and track and encourage adolescent immunizations. So Tdap and meningococcal are there. Those are both the federal chipper measures. We're trying to align with the federal standards. Those are the metrics, 5 and 6 on the chipper course side. We have also added HPV, and we're asking practices to report HPV for girls initially, because that is really what has been recorded in the National Immunization Survey data, and what is currently available that we can do. HPV for boys is a newer recommendation. Last year it was recognized that all boys should be vaccinated as well for HPV, partly because the girls were not being vaccinated, and initially they thought it would be more cost effective to do just the girls, but then they realized they weren't getting it, so now they realize that they've got to get the boys vaccinated too. So what we're asking now is groups can optionally report HPV for boys currently, and then mandatory is January 2013. So those, we're really trying to follow the national recommendations for this. How we came up with the point structure. So you'll see there's 2 columns in the middle. CDC national benchmarks. So what we did was say if you met the CDC national benchmark, you would get 3.5 points. This is based on the 2010 NIS rates. When we started working on this a year and a half ago, those were the most recent rates that we had. Obviously, there was rates last week. They come out every quarter, but that's what we had at the time. If you met the national average, you would get 3.5 points. What we did, Ted had asked us to look at where, if you were going to be in the top 10% of practices in the state, what rate would you have to get? So we actually, through the First Steps project, run on the back end what's called a COCOSA report. It's out of the federal CDC. Practices don't have access to this currently right now, but it's run out of the CDC, and they retrospectively look back and see, did you get your shots at age 2, 6, and 13? We provide these reports to practices. We are currently working with the Impact team through chipper and IHOC so that they are building this into their system so practices with a push of a button can print these reports out on their own. It doesn't happen quickly. So we've worked on this at the back end, so it now goes from Impact to the Office of Information Technology, goes to the Muskie School. The Muskie School does run charts for practices, and they follow their data. Eventually practices will be able to do it on their own. Just it's taking some time. So when we started the Learning Collaborative, at the very beginning, we looked at who would be, at the very top. How would you get the top points? So the groups that were at the 90th percentile, that's how we came up with the rates in the middle column, the 93, 94, 93. So if you hit that top percentile, you should be in the top group in the state. So like I was just talking about, currently practices can't run their reports on their own. That's why we're talking with you guys today, because we've developed this back-end way to get the reports out to them for PTE as a temporary measure. Some of you may have seen this, but in your handouts, there's actually a letter that went out to practices recently around the First Steps initiative, and practices don't report to First Steps, but report to PTE and how you can get your data and see these data reports. I'm just emphasizing it because I'll show you in a minute, we need them back by October 1st. And you'll see there's a form that goes out to the Maine Immunization Program that gets faxed to them. Once it gets faxed to them, any practice that currently reports to PTE, so there's 46 practices that currently reports PTE for pediatrics. And if you're a pediatric practice that doesn't report to PTE, but you've been in Impact 2 for more than a year, you will be allowed to do this mechanism as a temporary mechanism so we can get your data from Impact 2, share it with the practices, and then report back to PTE. So what happened is, it's sort of been a long process as well, to try to get the data flow piece worked out, because there's a lot of issues around who can share and see data. We've worked this out so the Improving Health Outcomes for Children are really, the CHIPRA project is taking the lead on this with the Office of Information Technology and this PTE. Quality Counts is stepping out of that because we work with the First Steps practices, but we're kind of stepping out as one of the mediators right now. So I just wanted to highlight to you. Your practice, if you're not in First Steps, and they'll know, needs to fill out this report and fax it back to us by October 1st. Once that happens, they'll get a data report back by early November. If a practice decides that they want to submit their data, and I'll show you what the report looks like, they need to submit it to PTE by November 15th. So it can be included in the January 1st update. Here is a sample of what the report currently looks like, and we've just done a trial, so if you don't like what the sample looks like, Muskie can also make it look a little bit different. But they've actually put up here what the point scales are. You'll see the metrics, you'll see what the practice got, how many points they got, where they got for best, total points, 93. And then they'll get this in a PDF format. There will be an identifier number here for the practices. They get identifiers from Muskie. They're not going to get, their name is not going to be on it. There's going to be an identifying number, and they'll get what that identifier is just for security and data transfer reasons. And then they'll be able to submit this to PTE. The whole submission issue with PTE is still, the process is still being worked out a little bit, but that's what it looks like. We've done a trial run with the First Steps practices, just with their July 15th data, recent data. So currently, one practice got best of 90 to 100 points. One practice just missed by 0.5 points. So when we run this again 2 months later, we're hoping that we have 2. 9 practices were in the better, and 8 practices were in the good range. One practice actually did not meet good, and we've looked at their data a couple times now with them. And one of the things that we found is when they look at Impact 2 currently, what they can see is their current rates, and it counts their catch-up rates. They actually look good. They've done a lot of work on recall reminders, a lot of work on catch-up data. It's going to take a little bit of time for their vaccine rates to go up with our COCASA reporting the AT2 and AT13 to get them into the good range. But they actually have done a lot of work, and they should be into that in the next few months. They actually get their data every quarter, so as they come up into the good range, they can then submit to PTE. But for the practices that are not in First Steps, that are outside of this process, here is coming up because it's a lot of work to run these reports on the back end. It actually is 6 or 7 pieces of reports per practice that goes to Muskie, gets put in charts and analyzed and gets set out. So because of that, we're going to run it as a one-time run so they can submit to PTE this fall. And then this spring, they'll have one more chance, and we're hoping by that point Impact 2 is going to be in place so they can print their own reports. But Kara wants to talk to you a little bit about the timing piece.